We kind of alluded to what this is about. I'm Layan. I'm one of the medical trainees, but I'm taking a year out to do this DASI fellowship in sickle cell. And I've been involved in the rollout of these changes in the sickle cell acute pathway. That's actually been, coming under play for a few months now, before I even started here. So I'm sure this is for a lot of people. So just very brief about sickle cell. So 15,000 people in the UK, and more than half are in London. And their presentations can be quite varied, but usually can be split into kind of three main things: either vaso-occlusive episodes, hemolysis, or end organ damage. And their acute presentations, again, can be quite varied, and in terms of risk, can be from one end, what we call a simple vaso-occlusive crisis, which is a very painful crisis, and on the other end, a potentially life-threatening event. And so that's why it's always important to remember the syndromes such as acute chest syndrome, stroke, and sepsis in patients with sickle cell in their acute presentations. In November 2021, there was an all-parliamentary party group report published, and this was looking into the serious failings in care and preventable deaths in patients with sickle cell. And across the nation, there's been a poor adherence to national guidelines, and especially there's been a large discrepancy in care for patients who have been treated in the A&E or acute wards versus a specialist ward, a specialist hematology ward. And they put that down to low awareness, inadequate training, and negative attitudes underpinned by racism. In our trust, we have a similar report. So we have a series of data access incidents in our trust, including in this year, I think, a few unexpected deaths. And so this has raised an awareness for us to all improve care. So things that have happened so far is PCA training has been increased. It's now nurses in Risa, Straight Ward, and James Ward, the outliers would have all been trained on PCA training. And there's 4 dedicated beds on Drake Ward with the dedicated outlier as James Ward. And today we're going to talk about the new pro forma, which is the ED sickle cell emergency call and the ED pro forma. So in ED, there are some slides. Only recently did this change. This was supposed to be for the whole hospital, but actually we now just limited to ED. The wards felt that this was an inappropriately low target or trigger for Drake Ward and James Ward. So it's only been for ED. So any patients with sickle cell coming in with a new score of 3 or more, or that's less than 94%, is eligible for a double two sickle cell emergency call. And that would go out. That, unfortunately, we couldn't get a specific call for that. So it's actually linked with the major hemorrhage bleep. So actually it will come out as a sickle cell call, but everybody who holds the bleep for major hemorrhage will get that call. But it's for the ED reg or consultant, the hematology reg within hours, the med reg on tape, and the ITU reg. But because of the way that coding works, the anesthetic ITU, the anesthetic bleep will also get this call, but it's for the ITU reg, plus or minus outreach. And that is to make sure that we get early senior MDT input and identification of care, so who the patient's going to be kept by and where they should go. And then on the guidelines, which is going to be up on the intranet hopefully before Monday, the launch, are going to be the indications for HDU, ITU, and transfer to Hammersmith Hospital. And so this is what the guidelines look like. Like I said, initially, it was for the whole hospital, but that's been reviewed and now it's only for ED. We've spoken to Switchboard, and so they hopefully won't put in any calls from the wards as a sickle cell emergency. They would have to meet the criteria of medical emergency. If that's making sense, sorry if it hasn't, but it will be emergency, a sickle cell call from the ED department for those parameters. And this has been agreed on by the Task and Finish group, which has the lead from emergency department, haematology, and from ITU as well. And it's agreed that they would be at the patient side within 15 minutes. Alongside this might not be affecting ITU as much, is the ED pro forma. So ED will now be using a specific pro forma for clerking in acute sickle patients, and that's just to streamline management and referral. And we'll be using that for auditing to see the improvements or the use of it when we eventually come around to auditing it. Within hours, they go ED refers straight to haematology. Out of hours, they go straight to the medical tape. Like I said, this slide probably not very useful for ITU. I don't know if any of you work in Ealing Hospital. Is that the case? No. If you do, then there is no haematology, inpatient haematology nurse at Ealing Hospital. All patients should be using the haematology team here, and if they're obviously as well, they will be transferred here. But again, if none of you are working at Ealing Hospital, this won't affect you. It's just that in that rare case that the patient is really unwell in Ealing Hospital, then the ITU reg at Ealing Hospital needs to attend. But if that's not the case here, then hopefully won't be affected. So, like I said, just a introduction to that new pro forma. I'm sure the bleeps will be starting from next week, and like I said, the launch is on Monday. It won't work from today or the weekend. I know that you won't be putting out the calls anyway because you have to be in ED. And also to get your feedback on your thoughts about it. I've been presenting to haematology, ITU, emergency department, and obviously getting lots of mixed feedback. Our next meeting is next month. So, there is an opportunity to change things, as well as when we audit, we can see if those parameters are suitable or not. Thank you. I've put a QR code there if anybody, can give feedback, but we can also discuss it here. Do you think I have maybe a few minutes if anyone wants to raise anything before I hand over to the pharmacist? I can go back to the slide because this now means that, as an ITU reg, you are attending another emergency call.
Okay. Does anyone have any doubt before I ask questions? Layan, first and foremost, are you going to circulate this protocol sheet in our unit? So we can.
Yes, if you want. I was going to put it all around the emergency department. Would it be useful in ITU?
Yeah, I think we will put up this poster in our office.
That's fine.
So that all of us, including the registrars, will be reminded about what are the things that will be needed when sickle cell crisis call comes out. Okay. I had only one doubt as far as this one crisis is concerned, because there have been instances where even I was involved. The patient had respiratory failure as well, secondary to the vaso-occlusive crisis. In such scenario, like there was a controversy whether to intubate this patient or no. Okay, because we all know that because it's a vaso-occlusive crisis, intubation may not help. So, have you made any kind of protocol or pro forma at what will be the trigger point for intubation, or can we follow the same standard of practice?
So there haven't been any changes in that, and I don't think that's very clearly outlined in the pro forma either. I think that so far it's been left to clinical decision, but is that something that you found to be an issue? I don't know.
Yeah, it was like a controversial issue. Like from our assessment, we would be preferring to give the patient, or rather offer the patient, non-invasive trial first. Okay. And if it's failing, then we might have to intubate him instantly. So at one particular point or one particular case, the problem happened that we delayed the intubation for nearly 12 hours. And later on CT chest, we found that this patient had severe RV dysfunction, secondary to vaso-occlusion as well. And there was one more scenario where we intubated this patient, but post intubation, we were not able to maintain the PO2 levels.
Yeah.
And I think correct, in both the cases, we couldn't transfer the patient to Hammersmith.
Because of intubation or
No,
other
he became a high risk in both scenarios.
they
The
were having.
patient became hemodynamically so unstable that he was extremely high risk for transfer.
Yeah. Yeah, and so you feel that there's a lack of protocol in
So
terms of
yes,
ventilation.
so we believe at that point there must have been like either a delay or we must have missed the trigger point to support the airway as well as provide appropriate cardiovascular support. That's how this is our learning point from those two scenarios.
That's really important for me. I'm just going to write that down because I've so far with all the teachings I've been, a lot of things are similar, not obviously the same as this. A lot of similar things have been brought up, and I guess things like that should look into. So, as a team, was there any kind of decisions that you thought would be useful? Is that something like a
Sorry?
reformer, or as in from that experience, what did you conclude?
I think we
Is the
need
fact
to
that you had to miss
have
the triggers beforehand, or they deteriorated too fast to actually benefit from NIV?
they did not tolerate NIV.
Oh, I see. They were
I
trying.
mean, one of the patients, the other patient was intubated straight away when he started developing symptoms.
Yeah.
So, like you mentioned in one of the indications for HDO stay is when the oxygen requirement was rising. So at that trigger, we had intubated this particular patient,
Yeah.
but definitely he developed hemodynamic instability as well.
Yeah.
So we would like to, or rather have an input from you as well that uh, do we need to support the airway and cardiovascular system as earliest as we can, rather than depending on news or oxygen saturation or anything.
Yeah, I don't know if I'm the right person to kind of dictate on that, but I would definitely be able to find out. I think so far it's been kind of put down to your experiences and expertise in when to intubate and when to not. And that's why it wasn't included on this on the indications.
Anyway, does anyone else have any other doubt? So, Layan, thank you very much. And hopefully by Monday, we will be putting everything in place.
Yes, so the bleeps will be going out, and if anyone has any, obviously sometimes the feedback is after something's happened, but when these things start happening, if there's any feedback about the mechanism or the way it's working, I'm happy to receive emails. I think I'm the only Layan in the trust, so I won't be hard to find. Yes.
And I will also encourage others who are both registrars as well as SHOs. Whoever is interested, do contact Layan for participating into this audit. It might be quite a very useful audit, not only from your portfolio point of view, but even getting more and more learning point and even improving the quality of outcome of the ICU. Thanks a lot, Layan, one more time.
Thank you so much.
And after this, we'll start the journal club. Tony, before that, I would like to know, do you want to do your presentation on the grab bag process?
I can do it afterwards.
Okay, that is fine. So
sorry. And should I give you